etc. But these are the main things which we are going to cover it. And it will be a good idea to go through all of these uh, after this session. So, uh, case one. Just one second, candidate. One, this will be your case. Let me show it on. So, uh, candidate
Yes,
one, can you speak?
yes, sir, I can hear you.
Okay, can you ask for the mouse?
Yes, sir. I requested.
Ask for it again, please.
Yes, sir, I requested.
Unfortunately, I cannot see anything on my screen. Once again,
Yes, sir, I once again um, put a request.
mm, maybe there is a technical issue. Okay, so let's start. I will scroll through it, and I will because the main idea is anatomy. So keep listening. I'm scrolling through it, and then at a particular point, I'll start asking questions from you.
Okay,
So
sir.
we are going superiorly. We have gone into the middle cranial fossa, and then we have come down, and we can see the mastoidal cells. What is this structure, candidate one,
This is the mastoid part of the facial nerve.
of the facial nerve?
Yes.
Okay. Now we are coming inferiorly. We are coming inferiorly. And here, just to orient you, what is this where I'm pointing out?
External auditory canal.
Okay, now you're oriented where we are. So uh, we are, I've gone up superiorly once again. Which part of the middle ear is this where I'm pointing out?
Uh, Sir, I cannot see your arrow.
Let me, uh, cannot see my arrow.
Sir, your arrow is right now at external auditory canal on the left side.
I'm working through two laptops and I can see my arrow.
Sir, right now your arrow, which is shown to me, is in left external auditory canal right now, and we are in the middle ear cavity image. Yes, now I can see your arrow. These are the middle ear ossicles. You are pointing out at the
Again,
malleus, left ear middle ear ossicle malleus.
And which part of middle ear is this?
Uh, Sir, here we are in the lateral to medius in the epitympanic recess, and this is here is where is arrow right now is cut.
Okay. Now I'm going inferiorly. So here you can see the arrow at the external auditory canal.
Yes, yes,
So
sir.
which part of middle ear is this where I'm pointing out? Black space.
Sir, this is inferior part in hypotympanum.
Where is mesotympanum?
Mm, uh, just below this middle, yes, where we are right now.
Okay. Okay. I'm going uh, inferiorly. I'm going inferiorly. Which part of anatomy is this where my mouse is?
Sir,
The straight structure.
sir, I couldn't remember it right now.
Take you back to the middle ear cavity. Just to orient you, I have gone superiorly. This is the epitympanum, where we can see the head of the malleus and we can see the incus. Now I am coming into the mesotympanum, and here we can see the external auditory canal. So the tympanic membrane must be sitting here. We cannot see it on this bone window. As I'm going inferiorly into the mesotympanum, I can see some soft tissue here, some soft tissue here. And this soft tissue extends posteriorly like this. What do you think is this?
Sir, this soft tissue is most probably in the hypotympanum, and this can uh, this can be Cholesteatoma from the pars tensa of the tympanic membrane, which is extending to the hypotympanum.
Right. Now, uh, anybody in the chat, do you know what this is? Okay. Somebody has said this is aberrant left internal carotid artery. Okay, candidate one, thank you very much.
Thank you.
So this is aberrant left internal carotid artery with persistent stapedial artery. Uh, First of all, let me go through the case and then we will revise the anatomy. And I have selected this case just as an initial case to develop your concepts of anatomy. Uh, Basically, we will come back to the details, but the relevant portion is look at the carotid canal here. Carotid canal within the temporal bone has got initially, so I've gone into the neck. I'm showing you the normal side. I've gone into the neck. There is a vertical portion here. This is the vertical portion. Then in the Petrous apex, it becomes horizontal. So this is the horizontal portion of the internal carotid or the carotid canal. It goes superior to the foramen lacerum, which is known as the lacerum portion. and then it goes into the cavernous sinus. Here is the cavernous sinus. And you can well imagine that it will, with the cavernous sinus, it passes through the cavernous sinus. So we'll come back to this. But on the other hand, what is happening here? What is happening here is that if we go back to the horizontal portion, you can see that there has to be a bone in between the horizontal portion and the medullary cavity. There has to be a bone there, and there is no bone. So it is dehiscent. And this is even on a non-enhanced, you can make this diagnosis, not enhanced CT, that it is projecting into the mesotympana. And with that, it there is a branch here which is known as the stapedial artery. It goes, this is the stapedius muscle lies here. We'll come back to this part of anatomy. In usually when a fetus is developing, uh, there is an artery which has got this configuration, and as after birth, it is all obliterated. In this case, there is a persistent stapedial artery, but more importantly, there is an aberrant internal carotid artery. Now, suppose you are a surgeon and you have to do surgery here. So what will happen? If you go in, you might find, a reddish type of tympanic membrane and you think something is happening. And if you go in and you nick it, it will be a disaster. So that is the importance. This particular case presented with pulsatile tinnitus, and this is one of the causes of pulsatile tinnitus. I don't think so. This case per se is an FRCR level case. It is slightly more specialized. So I don't think so. It will be for your exam. Having said that, it is a beautiful case to learn anatomy. So this is where we start. Now, let's go back to a bit of teaching. And there is going to be a uh, bit of uh, repetition from the last session, but you have to repeat it. This is what this session is about. Next session, I've decided that we will take it further and we will go into the base of the skull and PNS and orbit. So that will consolidate whole of this area. If you see here, look at the skull lateral, and this is the temporal bone. The red bone is the temporal bone. Whole of this is the base of skull. The red bone is the temporal bone. I'll come back to the temporal bone. Anteriorly is the sphenoid bone. Here is the occipital bone. Here is the frontal bone, and this is the ethmoid bone. So in next session, we will cover base of skull, all of these things, and there will always be a bit of overlap. Even today, I have intentionally not selected a few cases from temporal bone, which we will do in the base of skull session. Coming back to the temporal bone has got 5 parts. You don't have to learn, but just to emphasize. Squamous portion of the temporal bone, mastoid portion, tympanic portion, styloid process, and the petrous part of the temporal bone. The squamous portion is where the middle meningeal artery is. Irony is that this is the thinnest bone in the skull. Within the skull, this is the thinnest. And that is why it is prone to trauma and you will develop an epidural hematoma if there is a fracture here. And on the other hand, the petrous part of the temporal bone, which is our main interest, is the most complex anatomy of the human body, and which we are going to learn today. And it is a very, very thick bone. So if you see here, it is a pyramidal shape. Let me change my mouse to a laser. So You can see my mouse?
Yes, doctor.
Okay, good. So if you see here, this is the anterior surface, the posterior surface, and the inferior surface. On the superior is an arcuate eminence. Within the temporal bone, there are foramen. So, for example, carotid canal we just did, the carotid internal carotid artery passes through it. This is foramen lacerum. And the case which I showed you, the carotid canal, so the foramen lacerum per se is not a foramen in life. It is there is a some cartilage, etc., sitting there. So the carotid artery passes over it. It does not pass through it. But the portion which passes over it is known as the lateral part. I'll show you a diagram. And this is the cavernous portion. So if you see, this is the pituitary fossa. So you can well imagine that from here to here will be the sitting, the cavernous sinus. And you can see that the Petrous apex, which is this one, and I'll show you cases today about Petrous apex, which are exam cases, is sitting so close to the cavernous sinus here. So coming back to the carotid artery, it passes through it, then through the cavernous sinus, and then there is a supraclinoid portion. So I was talking about foramen within the petrous temporal bone. So one of them is the carotid artery. Then there are nerves which go in, and the nerves which pass in it are the seventh and eighth nerve. This is the internal auditory meatus, seventh and eighth nerve they pass through. Coming back, please remember this is an anatomy question. If somebody asks you true or false, jugular foramen is a foramen in the temporal bone, and the answer is false. Jugular foramen is a foramen in between the temporal and the occipital bone. This is the jugular foramen. It has got two parts. We'll come back to these, but this is part of our curriculum today. So I'm not going to cover the sphenoid, etc. That is for the next time. Now, if you see here, this portion here where I'm pointing out is the jugular foramen. And look at the shape. It has got two components. Anterior one is known as pars nervosa, and this is pars vascularis. The internal jugular vein passes through this one. So here, the the ninth nerve passes anteriorly, and the 10th and 11th pass here. You don't have to remember this, but just to add interest that which nerves pass through it, because then this is in continuity with the carotid sheath within the neck. So these nerves are passing. Key point to remember is that the 12th nerve, which is the hypoglossal nerve, has got separate foramen, which is the hypoglossal foramen. As soon as it passes through, we will learn the anatomy of the hypoglossal canal next time. As soon as it passes into the carotid sheath in the neck, sorry, as soon as it passes into the neck, it goes into the carotid sheath. So it goes with these nerves. And please remember, I'll show you cases where the pathology is sitting here. The pathology is sitting here and the effect is somewhere else. A classical exam case is atrophy of the hemiatrophy of the tongue, because this nerve, hypoglossal nerve, supplies the tongue, the intrinsic and the extrinsic muscles of the tongue. So what happens is if there is a lesion sitting here and the hypoglossal is destroyed, there will be atrophy of the hemitongue. And that is a FRCR case. I'll show you. So uh, coming, taking it further, if you see here, this is the jugular foramen, and which makes the point that this is the internal jugular vein, which is passing through the foramen. And this is, of course, the transverse sinus, and the sigmoid sinus becomes the internal jugular vein. So this is once again the internal jugular vein. Now, carotid artery, once again, if you see here, it is coming from the neck, it passes through the petrous bone. This is the vertical part, and then is the horizontal part. and we saw this horizontal part in this case. Then it passes superior to the foramen lacerum. This is the lacerum part of the internal carotid, and then will be the cavernous portion. So now coming back to uh, coming back to a global view of the middle ear. If you see, this is the middle ear, and we will come back to this in a while. Now, lateral to that is the external ear, and this is the external auditory canal. Superior to that is the middle cranial fossa, the brain. Uh, Medial to that is the internal ear. Inferior to that is the jugular foramen. Inferior to that is the jugular foramen, roughly speaking. And there will be some variations which I'll tell you. Anterior to this is the carotid canal. And posterior to this are the mastoid ear cells. So this is the concept of the middle ear. So first of all, the relations I have covered. Lateral is the external ear, medial is the inner ear, superior is the middle cranial fossa, the brain, inferior is the jugular foramen, anterior is the carotid canal, and posterior is the mastoid ear cells. So this is the key concept. Now let's go into details. So this is the middle ear cavity. This is the middle ear cavity. And this is the external auditory canal. First of all, the tympanic membrane. So this is the tympanic membrane. There is a bone here by the name of scutum, very important bone, FRCR bone, because this part where I'm pointing out is known as Prozac space. Prozac space is in between the body of the malleus and the head of the, the body of the incus, which is this one, and the head of the malleus and this bone. This is known as Prozac space. Cholesteatomas, anatomically speaking, are two types within the middle cavity. The most common is known as pars flaccida cholesteatoma. We will come back to that. And one of the things in pars uh, flaccida cholesteatoma is that the scutum, which is thin and sharp and pointed bone, it will be eroded. So you have to tell the examiner that I can see that there is blunting or erosion or amputation of the scutum. That is a key thing. So this scutum is a very important bone. Now, uh, from the scutum, the superiormost portion of the tympanic membrane is attached to the scutum. Inferiorly, it is attached to this annulus. We call it the tympanic annulus. So this is the tympanic membrane. If you draw an imaginary line from the scutum to this thing here, which is the facial nerve canal, tympanic portion, if you draw an imaginary line like this, straight line, from here till the annulus, if you draw another line like this, is the mesotympanum. I'll show you it to you again and again, because this concept will be asked in the exam. This is the mesotympanum. Superior to this, which is this one, is the attic or the epitympanum. And inferiorly, this trough like, which has got nothing there, will be known as hypotympanum. So this is a global view of the middle ear. If you see superiorly, there is a bone here which is known as tegmen tympani, and superior to that is the brain. And this bone becomes FRCR bone because you will be, they will show you cases in which it is eroded, and you have to tell the examiner that this is eroded. So scutum has got importance. This tegmen tympani has got importance. Another importance is of this structure here. What is this structure? This structure is the inner ear, and this is the vestibule, and this is the superior semicircular canal. This is the lateral semicircular canal. Lateral semicircular canal is an exam canal. Remember that because it is projecting here. There is bone here, and it is projecting and touching the in between the canal and the middle ear cavity is a bone, and this is normal. They will show you cases in which a cholesteatoma will be sitting here and will be causing fistulization of the lateral semicircular canal. So these are the key 3 points which you have to remember for your exam vis-a-vis any erosions, etc. Coming back to the ossicles. So we have got three ossicles, and portion of them are in the mesotympanum and portion of them are in the epitympanum. This portion of the malleus is attached to the tympanic membrane. Then it goes superiorly, the neck goes superiorly, and the head is sitting in the epitympanum. Second bone is the incus. Incus has got a body. This is the body, this is the short process, and this is the large process. Please remember that the body and incus and the short process, sorry, are sitting within the epitympanum. But the long process, it dips down back into the mesotympanum and makes the joint with the stapes. This joint is again an exam joint. Remember this. This is the head of the malleus and this is the incus. This joint is incudo-malleolar joint. Incudo-malleolar joint. And they will show you trauma cases, brain trauma cases, in which there is dislocation of these joints. This joint is known as incudostapedial joint. And by the way, in real life, we can actually pick up dislocation of this joint. But in the FRCR, they are not going to show you, it's too much. But this one you can see in any CT. This bone is the smallest bone of the human body, and it is known as stapes. Stapes joins the oval window of the cochlea. This structure here is the anterior crus, and this is the posterior crus. This is about 0.58 millimeter in thickness, and interestingly, on the present era CT scans, we can see it because the slice is 0.62. So, uh, once again, this is portion of the malleus which is attached to the tympanic membrane. Then the head goes into the epitympanum, and then this is the body of the incus, short process, the long process, incudo stapedial joint, anterior process, posterior process, and this is the foot plate which is on the oval window of the cochlea. This is the internal ear. Luckily, it is beyond FRCR. So I am not going to teach you in great detail. That is, an FRCR exam is what we call a general radiology exam, and there is they don't expect subspecialty type of things, congenital abnormalities and everything. So, but you should have a general idea that this is cochlea and how cochlea looks like on a CT scan, and this is the vestibule, which is made up of utricle and saccule. This is the superior semicircular canal, the lateral semicircular canal, and the posterior semicircular canal. So this is what we call membranous labyrinth. There is the terminology is there is a bony labyrinth and there is a membranous labyrinth. The bony labyrinth is very well seen on a CT scan, and anything which has got fluid inside is the membranous labyrinth, which is seen on MR. So we are not going to go into the details of endolymphatic duct or perilymphatic duct and endolymphatic sac, etc. Uh, One thing which I always tell students that endolymphatic sac, this thing, just remember that it sits on the posterior wall of the Petrous pyramid. There is one tumor, which is endolymphatic sac tumor, which can occur with VHL, von Hippel-Lindau syndrome. And radiologically speaking, it will be ugly, it will have enhancing features, it will, it will have destruction, but it's a very rare, very, very rare tumor. So as far as my knowledge goes, nobody has asked it in the exam, but uh, just remember that there is a tumor. I don't teach it actually, but there is a tumor which arises from endolymphatic sac, and that is in VHL. So suppose you have got a long case, etc., where you have got other stigmata of von Hippel-Lindau in the body, and temporal lone lesion is given, it might be an endolymphatic sac tumor. So I always teach um temporal bone vis-a-vis the facial nerve because it passes through it, it courses through it. This is the schematic diagram on which we will make our concepts. So this is the seventh nerve it arises from the pons, it passes into the internal auditory meatus, then goes into the bone. This portion is known as labyrinthine portion. This is the anterior genu and this is the posterior genu. Here is a ganglion, which is the geniculate ganglion. From the geniculate ganglion arises a nerve which you don't have to worry about, but this is the greater superficial petrosal nerve. It makes a plexus here, pterygopalatine plexus with other branches of fifth nerve. And this is responsible for lacrimation, submandibular, lacrimal gland, and parasympathetic supply, lacrimation as well as parasympathetic supply of sublingual and submandibular. Now, coming back, uh, so we are not worried about, but this concept should be known to you. But this, from the geniculate ganglion, the facial nerve turns 90-degree backwards, and this portion is known as tympanic portion, and this portion is very well seen on a CT scan, and I'll show you. And then it goes posteriorly, and then it goes vertically down. Where it goes vertically down, this is known as the mastoid portion of the facial nerve. It passes through the stylomastoid foramen and then goes into the parotid gland. At the parotid gland, it will give its terminal branches. So this diagram tells you the same thing once again. So this is the within the CP angle cistern. This is the labyrinthine portion. This is the geniculate ganglion. This is the tympanic portion. This is the mastoid portion. This is the stylomastoid foramen. Next to it is the parotid gland, and here it divides into its terminal branches. Another branch which is highlighted here, which you should know that the descending portion, there is a muscle here, which is the stapedius muscle. Stapedius muscle. The nerve is there is a branch here which supplies it. And remember the case one which we show was aberrant, persistent stapedial artery, which was supplying this part. As it goes down, there is another important branch which comes out. This is the cauda tympani. Cauda tympani actually is responsible for anterior two-third taste from, so it supplies the taste from anterior two-third of the tongue. On an axial, now concentrate on this axial because we are going to see the same thing on CT scan. This is the pons. From the pons, two nerves are coming out and they go together, sort of imaging wise, they go together. One is the vestibulocochlear nerve. Vestibulocochlear. So there is one component which comes from the cochlea, which is the cochlear nerve, and there are two nerves which come from the vestibule. These are known as superior and inferior vestibular nerves. So two nerves are coming here and one nerve is coming here. They join here and that will be the vestibulocochlear nerve, eighth nerve. But just superior to that, just superior to the level of the cochlea is the seventh nerve. This is the seventh nerve on an axial slice. As soon as it enters the bone, this is the bony part. This is known as the labyrinthine part. This is the geniculate ganglion. It passes posteriorly, and this is the tympanic portion. And then it will descend down. And as is seen on this diagram, it descends down like this. So this portion, this nerve is the greater superficial petrosal nerve. We can see this very well here. The labyrinthine portion is visible here. This is the geniculate ganglion. One point which I forgot to tell you, one landmark is that this is the lateral semicircular canal, and the facial nerve passes below it. Remember that, in the medial wall of the middle ear. So this is the middle ear. And if you see here, this is the geniculate ganglion. It will pass. Now, this structure here is the lateral semicircular canal, and this will become clear when I'll show you on a DICOM image. It passes posteriorly like this, inferior to this. This is the facial nerve canal. And on a sagittal also, you can see that it passes like this. We call it the hockey stick appearance. The coda tympani can be seen on imaging. It arises and passes anteriorly. It is responsible for taste from anterior to third of tongue. So on an MR cis sequence, on a sagittal oblique, you should have clear-cut concepts that you will see four nerves. So orientation-wise, this is the cerebellum, this is the anterior, this is the posterior. Here you can see four nerves, and the formula is 7 up, coke down. Uh, the seventh nerve, which is superior to the cochlea, is this one. This is the cochlear nerve, which is here anteriorly, superior vestibular, inferior vestibular. And I told you last time also that one of my registrars, she got this uh, in the exam. Actually the examiner opened it here, you know, sagittal oblique. So this was this first sequence, and the questions were about anatomy. So you should know this, that on a cis sequence, how it shows. Now, once again, repetition of the room concept of middle ear. Now, concentrate what is in which, this is the middle portion, which is the mesotympanum. If you draw a line, this is the tympanic membrane. If you draw a line at the superior edge and passes through the facial nerve canal on the medial wall, inferior to that, and another line which you draw at the edge of the tympanic membrane, the annulus. This will be the mesotympanum. Hypotympanum is just a trough which has got nothing more than that, inferior to that. Within the mesotympanum, we can see that part of the ossicles are there. Then on the medial wall, this is what we call the promontory of the cochlea. This is the stapedius muscle, and the oval window will be here. This is the lateral semicircular canal, and inferior to that is the facial nerve canal. Now, posteriorly, if you look posteriorly, before we go posteriorly, we go superiorly. So this portion superior to that is the attic or the epitympanum, where the head of malleus and the incus is. And this bone is the tegmen tympani, which is in between the middle ear and the brain. Now, posteriorly, there is an opening here, which is known as editus ad antrum, because on the other side is the mastoid antrum, and then the mastoid ear cells. So once again, I told you the walls, the lateral wall of the middle ear is external auditory canal or the external ear. The medial wall is the internal ear. The superior wall is the tegmen tympani. The inferior wall below that is the jugular foramen. Anteriorly, there will be carotid canal. Posteriorly, there will be mastoid antrum and mastoid ear cells. So this is once again a repetition. This is the medial wall. You can see the promontory here. You can see the facial nerve. You can see the lateral semicircular canal. This is the medial side. This is the tympanic membrane, and this is the epitympanum, where you can see head of malleus and the incus, and this is the incubomalleolar joint. and this is the short process. This is the body. This is the short process, and this is the long process. This is, of course, the chorda tympani and the correction. This is the chorda tympani, and this is the descending portion. Okay, now just concentrate on the facial nerve on this. So if you see here, this structure here is the orientation wise. This is the internal auditory meatus, and the nerve which is now I am going inferiorly. As I go inferiorly is the cochlea. This flower-like structure, I call it the flower. The flower is the cochlea, and this is the internal auditory canal. So orient yourself by this. Go superior to the cochlea. Just go superior. I'm going superiorly. As I'm going superiorly, we can see this structure here. This is the labyrinthine portion of the facial nerve. It goes anteriorly, the geniculate ganglion, and on here, this is the lateral semicircular canal. This is the lateral. You can see it makes this circle. And lateral to the lateral semicircular canal is the middle ear. So coming back, please remember we are learning through the facial nerve. So the facial nerve, this is the tympanic portion where the arrow is, and you can see it becomes a straight line. I'll go up. So this is the lateral semicircular canal, and you can see how it is passing on this axial below the lateral semicircular canal till the time it it reaches the mastoid, the posterior genome. Here, if you look carefully, you can see the stapes here, and there are other structures which I'll point out in another series of diagrams. But right now, just concentrate on the facial nerve. So now I am going to go down. I'm going down inferiorly. It goes down, 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 and it goes ultimately through the stylomastoid foramen outside the temporal bone. You stretch of imagination, you can see that the mandible is sitting here. You can imagine that the parotid gland is here. So it goes into the parotid gland and divides into branches. So with this concept of uh, facial nerve on axial, let's see the facial nerve on a coronal. Now, on a coronal, we can see this is the cochlea. This is the cochlea. And I'm going into the internal auditory meatus. So this is the internal auditory meatus. You can see this is the labyrinthine portion where the arrow is. Now I stop here. And this is what can come in your anatomy exam also. And the examiners can also ask. There are two dots here, one dot here, one dot here. This is owl eye appearance. And this is the labyrinthine portion, and this is the tympanic portion of the facial nerve. Let me trace it. So I come back. So from the internal auditory canal, the labyrinthine portion, this is the labyrinthine portion. This is the medial eye. This is the lateral eye. It goes anteriorly, and here is the geniculate ganglion. And from there, it turns 90-degree backwards, and this dot here is the tympanic portion. Please remember the landmark. It passes below the lateral semicircular canal. So it is passing below, it goes posteriorly, it goes to the mastoid portion, and then it descends down like this. This is the stylomastoid foramen. So now, and just a quick one, on a sagittal, the descending portion is very well seen. So this is the descending portion. We call it the hockey stick appearance. And actually, you can see here where I'm pointing out the chorda tympani actually arising from it. So this is the descending portion. on a sagittal also, you will see it very well. Now, uh, let's go to a more global view of the temporal bone. So we have just concentrated on the facial now, right? Now let's have a global view, because in the exam you should have this kind of a view where this is the mastoidea cells, the mandible is sitting here, and here is the clivus, and this is the mastoidea cells. Then as we go superiorly, now this is the jugular foramen. You can see the jugular foramen here. And in this particular case, the Petrous apex is pneumotized. Please remember that can happen. So there are air cells, just like here, there are air cells here. Actually, on the right side, there are more. So this is just normal variation. As a landmark, this is the external auditory canal. Anterior to that is the TMJ, and this becomes a FRCR, your checklist, because they will show you trauma cases in which this thing will not be sitting where it should be sitting. And on an axial sequence, you should raise the issue that it is dislocated. So coming back, now if you see this is the external auditory canal, you can actually see a thin line here. Maybe it is projecting for you or not, I am not sure. But having said that, if you change your window, you can easily see it. Here, anterior to that is the carotid canal. So this is the carotid canal. Carotid canal, the vertical portion, and then the horizontal portion. And then, of course, here is the cavernous portion where I am pointing out. Coming back to the middle ear. So this is the external auditory canal. This is the tympanic membrane. This space is the middle ear cavity. And then we can see these ossicles. Actually, this is the stapes. And you can see this semicircular canal where I am pointing out. You can see this facial nerve canal. So this is the mesotympanum. This is the mesotympanum. Sorry, I go back. So this is the mesotympanum where the external auditory canal is coming. 3 points here, which on the posterior wall of the mesotympanum, you can see this pyramid where I'm pointing out. The facial nerve is sitting here. This is known as pyramidal eminence. And this is the facial sinus tympani and the facial nerve recess. You don't have to remember this bit. Uh, and the stapedius muscle will be sitting here. But the key landmark on the axial is the epitympanum. So this should be etched in your memory, this image. This is the epitympanum. Here, the head of Malleus and the body of Incus and the short process. You can see that there is an hourglass appearance. Hourglass appearance. There is anterior widening, then there is constriction, and then there is widening. So this is the epitympanum. This is the editus ad antrum. Editus ad antrum. And then is the mastoid antrum. They will show you cholesteatoma cases in the exam where this thing might be expanded. And that will what the examiner asks. So beware of that. So on a coronal, uh, I'm now showing you the global perspective. This is these are the mastoid cells. The bone superior to the mastoid cells, and which is the middle cranial fossa is here. This bone is known as tegmen mastoideum. Tegmen mastoideum, because they will show you cases in which it will be eroded. On the other hand, this bone, which is superior to the middle ear, it is tegmen tympani. Tegmen tympani. So tegmen mastoideum, where mastoidea cells are there. I'm going anteriorly, and this one is tegmen tympani. Now, so once again, you know that these owls are the facial nerve, etc. And now our interest is on other structures. So this is the cochlea. And this is the vestibule, this is the superior semicircular canal, and correction, this is the superior and this is the lateral semicircular canal. So, and inferior to this is the jugular foramen. So, with this, uh, this is the MR, and on MR, this is, you know, this flower. Flower is the cochlea, and the cochlear nerve is coming out in green, just superior to the level. Now I'm going superior to the level of the cochlea. So this nerve is the eighth nerve, vestibulocochlear. Now you can see another nerve coming out, and this is superior to the level of the cochlea. So this is the facial nerve, and the bony part of it is better seen on a CT. Otherwise, this part is better seen on an MRI. In the chat, this is the same quiz which we did last time. So anatomy part or the lecture part of it is finished, because now I'm going to show you 9 more cases after this. Now, do you want to repeat this quiz? It will take how many minutes? 34 and 4. I think 10 minutes or so. Do you want to do it? In the chat, tell me. This is a repetition. There is nothing new, but repetition is very important for you. There are quite a few no's and there are few yeses. So we what we'll do is I'll do a hybrid model. I'll not go for I'll not ask you. I'll just repeat what is written there. So we are not going to go through the quiz. I'm just going to repeat it. So this is the external auditory canal. This is the Petrous apex, and part of it is pneumotized here. And of course, this is the clivus, and this is the carotid canal. This is the jugular foramen. And the middle ear cavity is coming into view. This is the TMJ. Here we can see external auditory canal, the middle ear, sorry, this middle ear cavity, mastoid cells, and of course, this is clivus, and this is the Petrous apex. So please remember that this part of anatomy, the clivus, is technically the sphenoid bone, and a portion of it is sphenoid, and portion of it is occipital bone. But Petrous apex is sitting here. And next cut here, we can see mastoid cells, we can see stapes, we can see the cochlea, we can see the vestibule, and we can see the facial nerve. Here we can see head of the malleus and the body. This is the incubomalleolar joint. This is the Prozac space, which is extremely important, because if you see a cholesteatoma sitting here, you have to tell the examiner that it is sitting in the Prozac space. This is portion of the lateral semicircular canal. This is the facial nerve canal, which is sitting internal auditory canal. This is on a coronal. On a coronal, you can see these owls, labyrinthine portion, and the tympanic portion, owl eye, owl eye. And this is the scutum. This is the cochlea, and this is the head of the malleus. This bone is very important. This is the scutum. And this is again the Prozac space. This is the scutum. The owl eyes are still visible. This is the tympanic portion. This is the labyrinthine portion. And here we can see the superior semicircular canal, the lateral semicircular canal, and the facial nerve canal is inferior to the lateral semicircular canal. This is the lateral semicircular canal. And inferior to that is the facial nerve canal and the vestibule. And this is the descending portion, which is the stylomastoid foramen, and this is the descending portion. On a sagittal, we can see the same thing. Now, uh, before I start with the cases, uh, two cases which I am not showing you right now, but I am just on PowerPoint, I will, to develop your anatomy concepts, I will show you. So one of the case is, this is what I was talking about. This is the normal incudomalleolar joint. And this should be your checklist in a trauma case. They will show it to you on a brain trauma case. And this is an example where you can see that on this cut, you can see that this is what we call ice cream cone sign. And it is not sitting, the cone is not sitting, correction, the ice cream is not sitting on the cone. So this should be in your checklist. Another example where you can see that this is the cone and there is air in between, so there is dislocation of the two. Another thing which I wanted to, I'm not going to show you this case. I believe this is slightly beyond FRCR level, but I'm going to show you in a PowerPoint mode just to develop your concepts and of course your day-to-day reporting. Perineural tumor spread around cranial nerve 7, most commonly seen with adenoid cystic carcinoma of the parotid, ill-defined enhancing tubular lesion extending from the parotid tumor through stylomastoid foramen, and ultimately it goes into the brain. This concept is important for you. If you see here, this is the parotid gland. If there is a tumor sitting here, it goes, this is known as perineural spread of the tumor. It goes through the stylomastoid along the facial nerve. The facial nerve, as if it is fire, it goes along a wire. And from here, it can go all the way into the cranial cavity. Same concept. This concept is an exam concept. This one is slightly beyond exam, but this one has been asked in the exam because the foramen here is bigger. And here, uh, if you see there can be masticator space lesions which can pass through through the foramen and then go into the cavernous sinus, etc., etc. Base of skull, we'll cover it next time. So this is the facial nerve, and I told you that portion of the facial nerve, the greater superficial petrosal nerve, produces a ganglion here with branches of fifth nerve. So I'm showing you a case from our collection in which what happened was that the patient presented quite a few times with symptoms, but appropriate imaging was not done. And in lower motor neuron lesions, when you are worried about lower motor neurons of the facial nerve, please remember that it goes beyond you cannot just do brain imaging and sit on it because the lesion might be in the temporal bone or it might be in the parotid. So that's the key learning point. In this case, from the deep lobe of the parotid, there was a adenoid cystic carcinoma sitting there. And these scans were brain scans. Actually, they are not classical high resolution fat saturated for temporal bone. But here you can actually see, if you look carefully, you can see this dot where I am pointing out. This dot is the enhancing portion of the facial nerve, the descending, the mastoid portion. But what happened now here, you can see where, here you can see that the tympanic portion is also enhancing. But more importantly, you can see that there is a lot of enhancement in the internal auditory meatus. So this is perineural spread. In this case, what had happened is that because of the pterygopalatine ganglion, tumor went there and then through the branches of the trigeminal nerve, it pass into the cavernous sinus. You can see portion of it here. So there was perineural spread along the seventh nerve as well as the fifth nerve. So this is the fifth nerve, and you can see it here on how it is going superiorly. So this tells you the concepts of perineural spread. Okay, now we start with the cases. So candidate 2, let me candidate 2, are you with us?
Yes, I am.
Okay, so candidate 2, okay, this is your case. Let me give you the history.
Mm-hmm.
This is a 70-year-old left-sided periauricular swelling and tenderness pus plus external diabetic patient. Over to you. To ask for a mouse.
Sorry, I thought it's not possible from an iPad. Tools.
Okay, I'll scroll for you.
Okay,
Now,
thank you.
we are our swelling, tenderness, pus discharge from left ear, diabetic patient. So
Yes, so I can see an axial CT on a bony window. What caught up my eye immediately is soft tissue swelling over the left, possibly cheek area, and over the external auditory canal, with a bit of widening of the external auditory canal, actually, and some bone destruction and lucency around it. I can see the ossicles on the left temporal bones. So the inflammatory or infective process is not has not eroded into the middle ear. So on this slide specifically, I can see that there is quite a significant bony destruction of the mastoid air cells, and there's fullness of the mastoid air cells, and there is destruction. These coronal. On the coronal, on a separate note as well, there's degenerative changes of C2 dense, C2 odontoid peg. And again, I can see the destruction, the bony destruction and the widening of the external auditory canal on the left. There is also fullness of the mastoid air cells. I think on the top of my differential, I would first like to look at the same images on the soft tissue window to see the extent of the soft tissue Um, yes, so on the soft tissue window, I can see that there is heterogeneous appearance and swelling um, over the left cheek, and there's also um, heterogeneous appearance and fullness of the external auditory canal with the soft tissue material. There is also a bit of uh, gas, I think. Um, no, not really. It's probably, well, there is a bit of locules of gas as well. Um, and this is extending up to the temporal, to the left temporal bone, or sorry, to the left temporal subcutaneous tissue and soft tissue area. Um, Again, there's features of this destructive soft tissue mass to the bone and to the distorting the anatomy in the left
So
temporal
what
bone.
conclusion?
So I think on like trying to list my differential. So because the patient is diabetic, this could be like a fulminant otitis externa or a malignant otitis externa that is forming all this abscess and soft tissue destruction and extending into the ear. Um, Another differential would be a malignant process, but with the history of diabetes and also with hello.
Yeah, I said thank you.
All right. Okay. Sorry.
So this is malignant otitis externa. Now, candidate two, why did you go into the world of malignancy when you did it so well?
I think I felt pressure to say something else, like to say so I was going to go against myself and say I don't think it is malignancy because the patient is diabetic. It looks very much like an infection and abscess formation with bony destruction. So I think I would go first. I would first go for malignant otitis externa.
Okay, so you were trying to just discuss it and rule it out. This is what you were telling us.
Yes.
Okay, well done. That
Thank
was
you very much.
well done. So this was a simple case. This is what we call malignant otitis externa. And this patient, unfortunately, for other reasons, did not survive that day. And uh, we lost her because we had asked for initially a CT with contrast, but the patient became unwell and they, heart, etc. So I don't have another scan to show you. Having said that, this is malignant otitis externa. Now, in here, what we see is that the candidate did very well. If you see even on the bone window, so this is what the exam is about. Keep your minds open and then you can ask for a soft tissue window. The candidate did very well, where she said, I would like to see a soft tissue window. Please remember in head and neck radiology, and this is true for paranasal sinuses also, it should be your routine that though routine scans are not done with contrast, you must see the soft tissue window and they will show you cases there. And then it is legitimate to ask for a contrast or MR, whatever the scenario is. So she did very well because she pointed out that she asked for that window. So I like that. Now, if you see, look at the destruction, it's horrible. And everything is gone. And you can see even look at this TMJ where there are a lot of erosions, etc. We'll come back to the sagittal. Uh, sorry, the corona. We can see opacification of the mastoid air cells and the middle ear cavity. Candidate 2, I think in your hurry you use some other word for I don't think so. You said opacification of the mastoid air cells. What did you say about the mastoid air cells?
So I wanted to point out that it is filled with fluid rather than air, so it's not aerated anymore. So
You
maybe I should have used a
opaque.
different. Yeah.
That's use the word opaque, opacity, right? This is
Okay.
this. So use that word. There is a soft tissue opacity in the mastoid air cells, or they are opaque. That is how you, in temporal bone or paranasal sinuses, this is the word which you use. So,
Mhm.
and then the middle ear, the pertinent negatives will be that is there any middle ear or any mastoid ear cell destruction, as in the the mastoid. Now this is the mastoid tegmentum mastoidea, which is fine, and this is the middle ear cavity. So the opacity is there, but tegment tympani is fine. The ossicles are fine. So in head and neck, the main thing is what is the epicenter of the lesion. And you can see that this is external auditory canal, which is gone. And this is also completely opaque. Compare it from this side. But the epicenter is the external auditory canal. So this is what we call the malignant otitis externa or whatever. So it was well done by the candidate. Okay,
Thank you very much.
good. Next candidate, please.
Yes, I'm here.
So
Good night.
your case. Let me give you the history.
Yes, please.
This is 6-year-old, and the patient is 6-year-old crying pain in the ear, A&E case. From the A&E, the patient came in.
Patient crying from pain in the
So
ear.
a 6 years old child, very unwell, fever, pain in the ear. Over to you. Left ear.
So I can scroll, please.
Yes, you can. I think I've given you, yes.
So I've presented with uh, uh, bone window, plain CT without contrast, that's showing
Temporal bone, please. Temporal bone.
temporal bone. It's okay. So I have ossified paranasal sinuses, both maxillary and osmoidal ear cells, and also there is ear loculi is presented as anterior temporal space intracranial, and there is another soft tissue as the otitis and antrum. Also complete ossification of middle ear cavity, and there is FSI seen at the mastoid antrum. Also there is sclerosis of left petrous bone and mastoid ear cells. Um, there is mild obstruction of the thickness of the tympanic membrane and the retraction. Could be automastoiditis and complicated with intracranial extension of air. I need to show if there is a coronal study to show coronal imaging to assess the tegment tympani and the tegment mastoid, and if there is contrast study to assess the venous deep venous system and the severe sinus.
Just 1 second, please. I've given you coronal.
Okay. So I have scrolling coronal view. The temporomandibular joint is unremarkable. There is no dislocation or subluxation. I have presented with also the external auditory canal, and there is ossification of middle ear cavity, and the tegment tympani looks there is erosion or wide thinning and probable erosion. There is ear loculi is seen here and non-dependent, and the tegment tympani looks like interrupted, or there is erosion or destruction of tegment tympani plate. So this is maybe the patient presentation could be consistent with automastoiditis complicating intracranial extension. Okay, the soft tissue window, that there is epidural collection, and there is foci seen non-dependent could represent epidural empyema. Uh, 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 so if there is contrast, I will contrast study. I will
So
show if there is the enhancement or if there is diffusion restriction. I will see if there is diffusion restriction to differentiate. simple collection from empyema.
Okay, thank you. So this was acute mastoiditis with epidural abscess. I'll come back to the case shortly. And this is from your book, acute mastoiditis with abscess. So clinical, of course, is very important. You have to look for any, of course, the opacified mastoidea cells, cortical or trabecular erosions. The candidate did well, where the candidate was looking for any dehiscence, and at places, some suspicion was raised, and there were minor, erosions and cortical dehiscence. And there was a brain abscess. And with that, always, so again, candidate did well, where was worried about other things happening and asked for next exam, which I'll show you. So please remember, in head and neck, most important for FRCR are complications of infections, may it be for paranasal sinuses or temporal bone or whatever. So, and because these are the types of patients which present in the A&E, and this is what the examiners are after. So they want to see that you are a safe radiologist, even if you are not a classical subspecialty head and neck radiologist. You can pick up these things. Any radiologist must pick up these things, any radiologist. And this is what FRCR exam is about. Now, in this particular case, uh, though I have not given you bone window, but you can see this destruction happening. And with that, there is a, if you see here, there is a soft tissue abscess. With that, if you see the jugular vein, there is a filling defect in the jugular vein, the sigmoid sinus filling defect, and the transverse sinus filling defect. So again and again and again, these cases come, and it all depends which modality they are showing to you. Similar to the case which I showed you right now, look at this one, another one, in which we can see that there is opacification of the mastoidea cells, and there is an air bubble sitting in the middle cranial fossa, and there is opacification here, and you can see that there is dehiscence of the bone here. So it is quite similar to the one which we saw, but the dehiscence is more pronounced. In this particular case, these words, when I show you an MR, though I did not show an MR to the candidate, but if I show you an MR, you have to see for any meningeal enhancement, mention that. You have to see the brain parenchyma. If the brain parenchyma is abnormal without any abscess formation, we use the word, cerebritis, which is a journal term that, infection is going in. Uh, if there is an abscess, then call it abscess. Always, always look for venous sinuses. Of course, in this case, we already know that there is a dural venous sinus thrombosis, but we can see that there is meningeal enhancement, and we can see that there is cerebritis. So now let me go through the case. Uh, Candidate 3, one thing, just like the previous candidate, you should have asked for a plain, soft tissue window, right?
Yeah.
So, and you can see it's a, though you had picked up the finding, but you are more confident that there is an abscess. So, as a rule, ask for soft tissue window, and then you did everything else was fine. Now, in this particular case, we can see that this is the external auditory canal. As we come here, there is opacification of the middle ear. It is completely opacified as I go superiorly, and you can see that the tegmen, sorry, the epitympanum is also opacified. This is the editus odontrum. This is opacified. Mastoidantrum, opacified, and maybe just a bit of air is there, and this might be cause of infection. Most of the mastoidea cells, they are opacified with just a few air bubbles. Coronal is a good one. You have to ask for coronal so that is erosions, etc. Particularly, you will see very well. So of course we knew that there is an air bubble, and here the candidate did well, where was mentioning uh, suspicion of bit of. So here the bone is thin. These are, we are in the mastoidea cells, and one can see, I don't know if it is projecting for you very well, but I think one can convince that there are subtle dehiscences, particularly here where I'm pointing out. As so there is some sort of, so, and even if the examiner show you this case, they will ask you anatomy questions. What is this? What is this? What is that? And the only thing is that on a soft tissue window, though this is a bone algorithm, but even then we can see the abscess very well. So this is an abscess. So I've got an MR of the same patient, but this MR was done 4 days after. So that is why I did not show to the candidate. Uh, 4 days after, if you see here, that mastoidea cells are all full of fluid. You can see the same thing. And here anteriorly, the abscess looks slightly less. You can see this is epidural, this is extra axial, and you can see this air bubble, and this is the air fluid level here. So the abscess has reduced slightly, and so on a FLAIR sequence, it is not as clearly seen, but the main thing is it is extra axial, epidural. And we have got a contrast, which is here. And now you can see that it is sitting outside. You can see this meningeal enhancement, and this is leptomeningeal enhancement, and you can see that the enhancement goes inside. So this is the pia mater. So this enhancement, otherwise there was no extension into the brain parenchyma. So meninges are, and you compare this meninges with this one, and you can see it is enhanced. Okay, candidate 3, well done. Candidate 4, are you with us? Are you unmuted, candidate 4? I cannot hear you. Let me check. Candidate 4. I've lost you. Are you there? Yeah, you are there. I can see you. Make co-host. Can you unmute yourself, candidate?
Yes, sir. Yes, sir. I am here, sir.
Okay. Now concentrate on the right temporal bone. And I warn you, there is a bit of fine touch in this case. So everybody, please see it very carefully. It's a good one. Till now, I have shown you slightly simple cases. This one requires a bit of anatomy. So this is 84-year-old, right-sided chronic mastoiditis. Rule out a cholesteatoma. This is what they have written.
Okay, sir. I'm provided with the cone view, HRCT of the temporal bone, and
Shift it here. Okay, please continue.
okay, sir. Okay, sir. I'm scrolling, and I can appreciate that there is a loss of aeration in the right-sided mastoid air cells, along with the destruction of the mastoid air cells is noted. And then, as I scroll down, Okay, so there is opacification of the middle ear cavity is also noted, and the ossicles are not clearly visualized. And so there are erosive changes noted in the region of the mastoid as well. I would like to review it in the coronal window to look out the blunting of the sputum and also to look for the tegment tympani. And now, as I am scrolling upward, there is also loss of the aeration in the uh, Petrous apex also seen. The internal auditory structure, which include cochlea, vestibule, and the semicircular canals, are grossly unremarkable. Sir, I need a coronal section to.
Okay, you have said initially in your description when you were describing the mastoid air cells, you said that there is destruction also. Where is the destruction? Point it out to me in the mastoid air cells. This is where you started, right? Your description.
Yes, sir. Yes, sir.
Where is it?
Sir, if compared to the left, there is loss of the mastoid cells. So, sir,
You use the word destruction. So where is the
yes. Uh, sir, this loss of variation pattern and sir, there is opacification. I think I overcalled it as destruction.
correct that?
Yes, sir. I overcalled the word destruction. So there is loss of aeration and opacification.
Questions? Now, point out the middle ear cavity to me here. Point out.
This is the left, and on the right, this is the middle ear cavity, and I cannot see ossicles here, and there is soft tissue. There is opacification.
Point out the mesotympanum to me.
Okay, sir. Sir, if I go below the ossicular level, so this is the mesotympanum, and if I go above it, sir, this is the epitympanum.
Okay, now we go to the coronal. You were asking for a coronal.
Yes, sir, coronal. Sir, on the coronal, sir, I would like to, okay, sir, there is, sir, can you just fix it so I can see the contralateral side as well? I am unable to see the compare it for the comparison.
I'm just showing you a single, and usually in some departments they just send right temporal
Okay,
side,
okay,
left.
sir. Sir, there is blunting of the scutum noted, and the sharp blunted end of the scutum cannot be seen. And also, sir, the tegment tympani shows. So I would, sir, there's thinning of the tegment tympani noted. So I'm, sir, concerning for cholesteatoma formation, and I
Coming
can
to your
advise MRI with diffusion weighted images to confirm my findings. If there is restricted diffusion in this area, then, sir, this is diagnostic for cholesteatoma.
point out the scutum to me.
Sir, the medial most part of the external auditory canal, sir, this one is the scutum, and sir, this blunting of the scutum.
Just with a arrow, point out where is this.
Sir, this one.
Why are you saying that there is a cholesteatoma? Where is the cholesteatoma? Which part of the ear, middle ear, is the cholesteatoma?
Sir, this is the Prusak space, and then soft tissue or in the Prusak space, and then along with this, there is blunting and loss of the sharpness of scutum. Sir, that's why.
Where is the mesotympanum?
Sir, mesotympanum is above the sir, this one is the epitympanum, and this is the mesotympanum.
Where is the lateral semicircular canal?
Sir, lateral semicircular canal. Sir, so this lateral semicircular.
Show me the labyrinthine portion of the facial nerve canal.
Okay, sir. So this is the labyrinthine and this is the tympanic.
Is it normal?
Sir, sir, the tympanic portion is not normal. And
Oh, thank you. So what was your conclusion? Was a
so
pars, is it
cholesteatoma.
placida or pars tensa cholesteatoma?
Yes, sir. Pars placida. Sir, pars placida.
Okay, thank you. Okay, now listen very carefully a few slides about cholesteatoma. Now, if you ask me that other than infection, which is the most important part, actually sorry, this is not a, there's a typo here uh, on the slide which I am showing you. So the correct thing is that this is a pars tensa cholesteatoma. So please note that there is a typo here. This is a pars tensa cholesteatoma with erosion of facial nerve canal and fistulization of lateral semicircular canal. So we will come back to this. Now, if you see here, acquired cholesteatoma. So basically, what happens is that where cholesteatomas can be acquired, they can be congenital. Basic issue is that there is stratified squamous epithelium, which because of perforation of the tympanic membrane, it goes retracts inside the middle ear cavity. Skin has got this characteristics. The DNA wise, the skin cells exfoliate, so they keep churning more keratin, and this keratin becomes a ball, and this ball actually has got some properties to cause erosion, and this happens over years and years. Please remember that. And on a this will not enhance or anything. So uh, how do you, because this is going to be a always a clinical chronic otitis media, rule out a cholesteatoma. So on CT, we are not very good. About 50% of cholesteatomas can be picked up. But the principle is that you must have a non-dependent opacity with bony destruction. Please remember, bony destruction can happen in acute conditions like acute mastoiditis or acute otitis media, etc. So you have to be careful, and the clinical scenario will also be helpful. Now, if you see here, this is the anatomy of pars flaccida. Our case was pars tensa. So this is the Prozac space, which is the space candidate. What was this? Candidate 4. So this was the candidate 4, isn't it? Candidate 4, you did this case, correct?
Yes, sir. Yes, sir.
Okay, so your concepts just because you were mixing up between Prozac space and you were pointing out anatomy, which I'll show you later on, which was not what it was. So please concentrate on this case. Now, this is the anatomy of the Prozac space. This is the head of the malleus and the body of the incus. So the cholesteatoma is sitting here, and this will be visible when an ENT surgeon does oroscopy. They will see it clinically, and then there will be erosion of this bone, which is scutum. On the other hand, look at this cholesteatoma, which is much larger, which has caused erosion of the tegmen tympani. And here there is lateral semicircular canal, which it has eroded in fistulization, which is a exam scenario. So please remember that uh, you will see middle ear opacification. You can see these are the features which are commonly seen and might not be seen in each and every case. Remember that scutum can be eroded, ossicular erosion can be there, ossicular displacement, so it can displace the ossicle as a mass. expansion of editus ad antrum can happen. Lateral semicircular canal fistula, this is extremely important for the exam. These patients will be very symptomatic because they will be dizzy and etc. etc. Tegment tympani erosion, this is important. Facial nerve dehiscence will be there. In our case, which I have shown you, there is facial nerve dehiscence and there is lateral semicircular canal fistula. This is a case of cholesteatoma where you can see this opacity which is completely replacing the middle ear cavity, and it is causing erosion. Where are the ossicles? Because the ossicles are gone, that is erosion, and there is a opacity which is completely replacing it. This is the key thing which I want you to remember is the lateral semicircular canal. So this is the lateral semicircular canal on the normal side. This is the superior semicircular canal. Key point to remember is that there must be a bone between the lateral semicircular canal and the middle ear cavity. Here you can see that there is no bone. There is no bone. And this is known as fistulization, and this is classical exam scenario which you can see. This is what I call the Clint Eastwood sign uh, from old classical movie Good, Bad and Ugly. This is Clint Eastwood's gun. This is the barrel and it is touching this white. So this barrel, and this is the superior semicircular canal. This is this vestibule. This is the vestibule. So this should not touch the black. The barrel should not. You can see it here. So this is the Clint Eastwood sign, which is this is the barrel. It touches the white. This is the hammer, which is the superior semicircular canal, and here it is not touching the white. So this is fistulization of the lateral semicircular canal. Cholesteatomas can be very big. They can destroy everything. Please remember that they can destroy whole of the internal ear, and the patient might not have presented. So here you can see this cholesteatoma which is causing a lot of bony erosion, and look at the fistulization of the lateral semicircular canal. Here is a big one where you can see that the internal ear is also completely destroyed. You don't see anything, cochlea, vestibule, etc. And actually IAM is there, but it will take years and years for this thing to happen. So this is acute mastoiditis, acute otitis media and mastoiditis with destruction of the ossicles. You can see this air fluid level, and this is not a cholesteatoma. What I am trying to tell you here is that acute infections can also destroy ossicles and bone. But on the other hand, in cholesteatoma, it will be more chronic type of clinical, and there will be bony destruction. One cholesteatoma which I want to highlight is this one. So if you see, this is the medial side, this is the internal ear, this is the cochlea. Now you can see this is a non-dependent opacity, and how this is the epitympanum, and how it is causing erosion of the head of the malleus. So this should be etched in your memory. This is classical Prozac space. This is the outer side of the body. So let me go through this case. And this is a good one because there can be many, many things in the exam. I can go on and on and on about in this case. So now in this case, if we so orientation wise, this is the IAM, sorry, internal auditory meatus. This is the cochlea, and now this is the lateral semicircular. Where my mouse is, you can see lateral semicircular canal, and here, even on this axial where I am pointing out, there is suspicion as if this bone here is missing. So you should develop this reflex of how to pick up lateral semicircular canal. Now, if you see the normal side here, you can actually always see a bone, white of the bone, uh, abutting the lateral semicircular canal. So here, portion of it is missing. So if I want to give you very, very good marks, you should have picked it up on an axial sequence. And of course, there is opacity. Where is this opacity? Please remember that the Prozac space is this one where I am pointing out. So Prozac space is this space, which is outer space. This is the head of the malleus, and this is on the normal side, the incus. This space is Prozac space. Prozac space has got opacity, but the main opacity is sitting here on the medial side. So this is pars tensa cholesteatoma, and it is not in the Prozac space. And with that, on this, if I go superiorly, there is suspicion that there must be, this is the superior semicircular canal, there is suspicion that there might be some dehiscence here. So on this axial, but here, let's go to our good old facial nerve canal. You can see that this is the cochlea. I go superiorly. This is the labyrinthine portion. So let me go to the other side, which is the normal side. And you see, this is the labyrinthine portion, and this is how it should look like. Here, you can see that this thing is in communication with this opacity. So something might be happening there. Now, where is the tympanic portion? Where is the tympanic portion? Let's go to the normal side, which is this one, and trace it. Now, this is the tympanic portion, and you can see how it goes below, where I'm pointing out below the lateral semicircular canal. Here, where is it? Let's go back. And you don't see it actually. You see opacity here. And then it appears, where I'm pointing out, it appears below the lateral, and it goes, and then the mastoid portion. So I go to a coronal, and on this coronal, see what is happening. Now, first of all, this is the external auditory canal, and this is the this is the mesotympanum, and this is the hypotympanum. All of the opacity actually is sitting in the epitympanum, but this is the classical Prozac space. It is not sitting there. The main epicenter is sitting here medially, and then is it causing tegment tympani dehiscence? So we go up and down, and maybe here it is very thin, so we can raise that issue. But here, where I'm pointing out, there is a definite dehiscence. There is a definite dehiscence. Let's go and trace the facial nerve. So this is the internal auditory canal, and here, this is the owl, labyrinthine portion. It goes here, and now you are convinced. Where are the two eyes of the owl? They are gone, and they are abutting this opacity. The two owls are gone. So this cholesteatoma is causing dehiscence of the facial nerve canal. And please remember, very near to that was that erosion where I am pointing out. Now, if we trace it anteriorly, so this is the facial nerve, dehiscent canal, and then inferior to the lateral semicircular canal, it is normal where I am pointing out, and as we trace, it goes down. Coming back to the lateral semicircular canal, this is the lateral semicircular canal. And if you compare it with the other side, just 1 second. As I've told you, Clint Eastwood sign, it must touch white of the bone, right? It is not touching white of the bone. This is here. It is touching this opacity. There is no white here. So there is fistulization. So this will be a pars tensa cholesteatoma with fistulization of the lateral semicircular canal and dehiscence of the facial nerve canal. Okay, thank you. Candidate 5, are you with us?
Yes, sir.
Let me give you the history of this patient. this patient is, oh, so what happened was that this patient is 71-year-old, right-sided mastoid surgery 6 years ago. And initially they have asked a CT scan and they want us to rule out a recurrent cholesteatoma. Just concentrate on the right side.
Okay. I have requested remote control.
I've given you the mouse.
Okay, I am going through the images and I can see that there is a soft tissue opacity and it is okay, I can see that the soft tissue opacity is destroying the right mastoid cell. It is occupying the right external auditory canal. I cannot appreciate a normal anatomy on this side since this is a post-surgical case. The ossicles. Uh, I can see the tympanic membrane. It appears normal. So this looks like a destructive lesion, which is. Can I see the soft tissue window of this patient?
And how will it help you?
I just want to see if
This is,
any.
yeah, what do you want to see in the soft tissue window?
I just want to see the external soft tissue involvement. How much is it? It is extending outside.
So, this is status post mastoidectomy. Mastoidectomies can be radical mastoidectomy, they can be partial. You won't gain anything out of it unless there is an infection, secondary infection. There is no infection.
Okay, so can I see the coronal view? Okay, this is the coronal view, and I can see that I can see the inner ear structures. They appear unremarkable. There is irregularity of the tegment tympani.
Where is the irregularity? Show me.
So this part appears irregular.
That can be normal. Okay, what is your
I
control?
can So this can be a recurrent mass, and it is non-dependent. So this can be a recurrent cholesteatoma.
This is the surgical cavity, surgical field. A normal mastoidectomy looks like this always. How can you confirm that there is a recurrent cholesteatoma?
MR, we can do MR for this patient.
Okay. MR.
Okay, this is T2 cornel, and I can again see some mastoidectomy changes here. Sir, can I see the diffusion weighted imaging? Okay, this is the diffusion weighted images, and I can see that there is a diffusion restriction at the same site which I saw earlier on CT. And this confirms that this can be a recurrent cholesteatoma.
Okay, thank you. So this was a recurrent cholesteatoma. Basically, what happens is, in post-surgical cases, as I'm reading from the book, it is hard to differentiate recurrent from granulation tissue, fluid, and fibrosis on CT. So we do DWI. This is what we call non-EPI, non-echoplanar imaging DWI sequences. Because otherwise there will be a lot of artifacts. And please remember that cholesteatoma by definition is epidermoid. Epidermoid and cholesteatoma is the same thing. And if it is in the skull, we have made life difficult for ourselves. If it in the skull, we call it an epidermoid. In the temporal bone, we call it a cholesteatoma. If it is in the intracranial cavity, we again call it an epidermoid, and it can be congenital and it can be acquired. So here, the key thing is that in post-op cases, the opacity on CT scan, it will always be opaque, just like in our case. And you are never going to, it's a surgical cavity. There is a concept of radical mastoidectomy where they might have removed everything. So you cannot differentiate because three things can be there. One is fluid, second thing is granulation tissue, and the third thing is cholesteatoma. Key point to remember is that the only thing which will show restricted diffusion is recurrent cholesteatoma. There was a concept that you do special type of imaging where you can differentiate between the three. How do you do that imaging? This is on this slide. You do 45-minute delay scan with contrast. Granulation tissue will enhance, fluid will not enhance, cholesteatoma will not enhance, and cholesteatoma will show restricted diffusion. By this technique, if you do with contrast 45-minute delay, you can differentiate between fluid, granulation tissue, and cholesteatoma. Counter argument is that why are you doing, even if you say it is granulation tissue versus fluid, it will not change management. So just do DWI sequence and correlate with other non-enhanced sequences, correlate the anatomy of it, and tell the clinician what it is. So here you are. This is a post-surgical case. This is 45-minute delay. And on DWI, there is no enhancement. So there is no recurrence in this case. In this case, there is recurrence because of DWI. And this is a bilateral case, had previous bilateral surgeries. And on the right side, you can see high T2 and on delayed post-contrast enhancement. So this is granulation tissue. On DWI, there is nothing. On the left side, there is no enhancement. On DWI, there is what we call restricted diffusion. So coming back to the description of this case, key thing is that you must develop your eyes on post-surgical. So this is all post-surgical appearance. Having said that, with this post-surgical, you can see this dehiscence where I am pointing out. There is a dehiscence and you can see that the intracranial cavity is there, and this dehiscence should raise the issue that something is happening. And on the coronal, Here you are. This is the cavity, and this is the cavity, and this is what we call tegmen mastoidium, and you can see erosion here, superior to what. So you never know what is what in this as far as a CT is concerned, but there is erosion. And this particular finding is of, yeah, so if you see here, this is the lateral semicircular canal, and this is portion of the superior, this superior wall of the external auditory. It is completely gone because of surgery. And this is the epitympanum. And so everything else you cannot make out. But key thing is that on a DWI sequence, you can see that there is a bit of restricted diffusion here and here. And you can see how it looks like it will be, the resolution will not be very good, but it will give you uh, the diagnosis, non-EPI, non-echoplanar image DWI. Okay, thank you very much. You got the diagnosis, but a bit of fine touch was there, lacking there. Otherwise, you got the
Thank you,
diagnosis.
sir.
Well done. Okay, now next case is 6-year-old. No, just 1 second. So this is a 52-year-old male, acute symptoms. Left, they're worried about the left side. They say acute otitis media. Over to you. Can you ask for the mouse? Who's the candidate?
Yes, good evening, sir.
Yes. Can you ask for the mouse? You know how to ask for the mouse?
Yes, sir, I know how to ask, but today the option is not showing up.
Okay, so let me scroll. So this was as a brain scan, it was done. So on the brain, you, you comment on the temporal bone.
Okay, so this is a bone window, CT temporal bones, in which there is an opacity seen in the middle ear cavity at the level of cochlea, as well as opacification and part destruction of mastoid ear cells. There is a dependent density seen in the surrounding the in the epitympanum, as well as mesotympanum, as well as surrounding the ossicles, which are part, actually they are quite eroded, and it is the dependent, because I can see air at its top, and there is part sclerosis of the surrounding bone, as well as somewhat erosion. Sir, I would like to see I would also like to see the Petrous apex, which is normally seen. So the epicenter is in the middle ear cavity and in the mastoids, with part dehiscence of the posteriormost part of the mastoid ear cells. Um, yeah, the focal loss of bone is there, sir. I would like to see the images on the coronal as well. These are sagittal images.
Sorry, this is slightly oblique. So I'm showing
Okay.
generator coronal, right? This coronal oblique type of because the patient could not cooperate.
Okay, so there is a focal loss of bone at the level of mastoids, with mm, the
Okay.
same findings are re-demonstrated. So
Okay.
if the patient has, yes, sir.
Yeah. What is your conclusion?
So if the patient has presented acutely with fever and constitutional symptoms, it can be acute mastoiditis, but I would also like to see the soft tissue window to see adjacent cranial status of adjacent brain. Mm, in the brain, there is a focal. Sir, can you please show me the area where of internal acoustic meatus? just and can you please change the window a bit? The soft tissue is appearing a bit hyperdense type. If you can just okay, yes, that's better. Um, there is hyperdensity seen in the adjacent region, but I'm not quite convinced about the.
What will you do?
Sir, I will do MRI, MRI contrast enhanced MRI
You
because
can
I've
get,
suspicion that it is mastoiditis, acute mastoiditis with bony erosion. So I'm quite concerned about the adjacent venous sinuses. So
so
to rule out any,
I warn you, if you have an infection in your exam, how do you deal with an A&E patient, by the way? You ask for an MR, right? In
sir, contrast enhanced CT.
and this is what if you start asking for MR, it might happen tomorrow, next day. So you should ask for initially contrast, and if the examiner wants, can show you the MR. Don't do this mistake because this is how radiology is practiced. Now, having said that, uh, an MR was done next day actually.
Okay. These are the no, these are the contrast enhanced sequences of the MR in the same patient in which there is a hyperintensity is seen posterior to the mastoid cells.
Need contrast enhanced.
Sir, sir, this is contrast enhanced
Why do you say that?
because I can see vessels in the temporal, yes, in the scalp and in the temporal fossa. Yes, at this point.
If you see a stir sequence in the pelvis, it will show you every vessel of the pelvis. Does it mean it's contrast enhanced?
Okay, sir, this is flare
And why do you say this is so?
because the brain parenchyma looks like a typical flare imaging. White matter is hyperintense. Gray matter is hyperintense.
Okay, so what have you picked up?
Sir, I've picked filling defect and fullness and hyperintensity in the region of sigmoid sinus, as well as a hyperintense area in the mastoid ear cells with adjacent significant soft tissue thickening and hyperintensity. So this is my conclusion is that this is a case of acute coalescent mastoiditis with adjacent sigmoid sinus thrombosis, and it needs to be urgently communicated to the referring physician for further management.
So, okay, so we stop here, madam. Who you pick your clinical practice. If this is the case which I have, you once you see it on the,
Sir, your voice is somewhat muffled. Can you please say
you know,
again?
the point is that in your day-to-day practice, in your clinical practice, when you see, uh, can you hear me?
Yes, sir. Now I can.
Okay. So if the point is that you have made this diagnosis on the flare,
Hmm. I
you,
should be saying T1 post
how do
contrast.
just think in the exam, you are reporting it in your day-to-day. Do you report it on a flare that this is an abscess? Will you?
No.
So this is what in the exam also ask for a sequence yourself. Be proactive. You should not have concluded the case here. You should have said that I want to confirm it. And you can ask for a TWI if you want, is there access? You can ask for a post contrast, things like that. So that is the main feedback as far as otherwise you have picked up the findings. So in this particular case, uh, this was again automastoiditis with uh, cerebellar abscess. This time it was a cerebellar abscess. And the candidate did well, where picked up the findings, and there was a dehiscence here, did very well to see on soft tissue window that there is nothing visible. Actually, there was none. One point is that in A&E cases, it is critical that you deal as an A&E case because the MR will be delayed. So you can also be elaborative and say that, I will do a contrast enhance, and if MR is available, it will be a better modality to highlight that point. Now, on this flare, so first of all, it was a flare. In flare, the white matter is black, remember that. And in a T1, white matter is white. So this is a T1 where the white matter is white. Now, so on flare, we can see that there was something sitting here. Now, where is it sitting? So one can ask for other sequences to confirm it. And in this particular case, this was, here you are. There was an abscess there, and this was actually an extra axial abscess. It was sitting just outside the cerebellum, touching the meninges. It was extra axial. Okay, thank you. Next, please. So the key point for you, candidate, is that the what you ask is critical. That you ask what you ask and how you deal it in day-to-day practice. Okay, now next candidate.
Thank you, sir.
Thank you. Next candidate.
Yes, sir.
Okay, your candidate number is
7.
7. Okay, so this is an A&E case. What happened is that this is 83-year-old, fall in the room. So she fell at home, and they are worried about any intracranial hemorrhage. So because of time factor, this is the brain. We don't see anything much, right? So anything else? Do you see anything else, madam?
Yes, I'm presented with CT scan axial sections. Here I can see that there is soft tissue
Excuse me.
pacification seen.
Excuse me. Can you ask for the mouse?
Yes.
Yeah.
Okay.
Just go to the base of the skull, temporal bone, and see if you.
Yes. There is a soft tissue opacification, soft tissue mass-like opacification seen in the region of the jugular foramen, and also seen extending into the region of middle ear cavity.
Where is the middle
Um,
cavity?
and the
Madam,
bony
where
plate.
is the middle ear cavity?
1 minute. Or I yeah, I can see it on the bone window, maybe. It's not in the middle ears. Sorry. The mastoid cells are also seen opacified, and there is loss of the there is loss of the bone with the at the region of the cerebellum, and there is opacification of the right mastoid air cells. Now on these images, I want to see the this is the middle ear cavity in the region of the aditus and mastoid antrum, and this epitympanium region. There is also a defect in the tegmen tympani over here. Mm, and there is a bony destruction in the region of jugular foramen. So it could be due to any mass lesion which is based on the in the region of the jugular foramen. I will like to proceed with the post contrast images if available.
Yeah, so actually, we have got an MR. Over to you.
All right. These are the axial sections of MRI brain.
Region.
T1 weighted images. Here I can see again the soft tissue mass, which is predominantly hyper to isointense on the T1 and giving some fluvoid appearances. These are characteristic of salt and pepper appearances, which are seen in for the glomus jugulare. I like to compare with the, any previous imaging if available and with the clinical symptoms if the patient has any symptoms of paraganglioma or
So what kind of symptoms do you expect?
I will like to see first extension into the tympanic cavity, as there are sometimes extension of the jugular into the tympanic cavity. Um, Patient could have tinnitus or
Okay, thank you.
okay, thank you, sir.
So this was a glomus jugulotympanicum. And so the glomus tumors in the middle ear cavity, the epicenter can be around the jugular foramen. When it is around the jugular foramen, we call it glomus jugulare. From the jugular foramen, if it goes into the middle ear cavity, then we call it glomus jugulotympanicum. And then there can be another one which can be just in the tympanic memory, tympanic cavity, as in the middle ear cavity, and we call it glomus tympanicum. Please remember that they are associated with various types of syndromes. So they can be familiar, they can be bilateral, and they can be what we call multiple. And interestingly, when they are in adrenals, we call them pheochromocytomas. So the point is that you can get long cases, etc., etc. So another in your book, there is another differential, which is jugular foramen lesions. Glomus jugulare is one of them. And so here, if you see this case, it tells you that there is a soft tissue tumor which is extending into the middle ear cavity, non-specific. When you give contrast, you can see everything is enhancing. So these are extremely enhancing tumors. These pictures tell you everything. So this is this is around the jugular foramen, and it has gone into the middle ear cavity, glomus jugulotympanicum. This one is completely filling up the glomus, the middle ear cavity. So this is glomus tympanicum. This is one which is sitting here. And so another picture showing you the similar thing. Key point to remember, on a CT scan, develop your eyes to see for permeative bony destruction. They are slow growing tumors, they grow over years, but because of their vascularity, etc., they cause permeative bony destruction like this. You see this permeative bony destruction like this. And this is how you differentiate it with the neuroma, let's say neuroma from any nerve. Another point which the candidate very well picked up, I had intentionally shown a T1 weighted pre-contrast sequence. These are extremely vascular tumors. And on a T1 weighted pre-contrast sequence, we have got salt and pepper sign, where there can be small hemorrhages or slow flow in the vessels, and high flow in the vessel is low signal. So this is salt and pepper sign. So these are two different cases. This is permeative bony destruction. It is a key sign which will differentiate it from a schwannoma. So, and salt and pepper sign. This is a schwannoma, and you can see that it is causing expansion of the jugular foramen. It is causing enhancement. So enhancement will not be very helpful. You remember the two signs on pre-contrast T1, salt and pepper, and permeative bony destruction. Look here, how, look at the outline. This is permeative bony destruction. This is a schwannoma on an MR, which is enhancing and it is going into, so, it can be from any cranial nerve of this region. This is a schwannoma. Wherever schwannomas are, they will cause bony expansion. This picture also tells you how the radiological features of a schwannoma will be. So, in differential diagnosis, meningioma, you have to consider in this region, when meningiomas are there, there is a concept of intraosseous extension and there will be hyperostosis. This picture tells you, next time I'll show you a few cases of meningiomas which are going into the bone. And please remember in the exam, because of hyperostosis, they might show you a plain X-ray where there is hyperostosis, and temporal bone can cause, is a known site. So this is once again jugular foramen cases. Now we go to so the key thing here is that so first of all, classical exam scenario on a soft tissue window. Please remember today we are doing temporal bone, so your mind is knows that it will be something there. But this is a case, and it goes into the carotid space from here. Ask for the bone window, and now see that sign of the software actually is hanging, so just bear with me. Now it's fine. So if you see, look at the edges here, and this is the permeative bony destruction, and this is a key exam sign in this case. Look, mention that this is permeative bony destruction. Then the candidate did very well. I showed T1 without contrast, and here you can see this salt and pepper sign. There are high signal, and where there is low signal means these are vessels which have got high flow, very high velocity blood, which is low signal, and how it is going into the carotid space. So just to make a point that if you see the patient has moved a lot, but you can see how it enhances. Enhancement will not make a difference, but these two signs are critical. Okay, well done. Now, this patient, candidate, what is the number of candidate?
Assalamu alaikum, sir. Candidate number 8.
8. So here, if you see here, this what happened was that I'll show you this in a PowerPoint mode because just before the this session, I just realized that the appropriate MR has not been downloaded. So this patient is interesting because it is 62-year-old and initially presented with acute mastoiditis type of findings, and this was the original CT scan.
Okay.
And we can see that there is opacification, etc. And we can see that there is otitis media, and maybe there is a bit of erosion here. Nothing new. I've already shown you quite a few cases like this. The patient initially became better on antibiotics, etc. And but after 2 weeks presented again with symptoms. And this time, patient had developed sixth nerve palsy. So I will show you in a PowerPoint mode, and so your Viva case will be in PowerPoint. Uh, so 2 weeks later, the patient presented with diminished vision, left eye with left sixth nerve palsy, which is the lateral rectus, right? So this is a weighted sequence. There is nothing much here. So this is a fat saturated flare sequence.
Okay, sir.
The Petrous
Um,
apex, anything happening there in the apex?
sir, do I have to tell you on this, or do I have to ask you for the remote?
No, no, no. This is a PowerPoint. So it's
Okay. Okay, okay,
you just
sir. Yes, sir. I can see that there is extension of the process, the infective etiology, I suppose, up to the Petrous apex, and if the sixth nerve is involving, and the patient is having palsy of the sixth nerve, lateral rectus muscle, it should involve the cavernous sinus as well. And in the first image, I can see that the process is extending upwards towards the cavernous sinus as well. Um, this is the extension of the process into the base of the brain or to the cavernous sinus region. So in the first row is the plain coronal sections, and the second row is the post contrast, and the level of the lateral wall of the cavernous sinus, I guess, which is also somewhat abutting the carotid ICA, internal carotid artery. So this is basically extensive Petrous epicitis, which is leading to palsy of the sixth nerve. So this is an emergency, and will refer the patient to the ENT and eye department for further management. The other name for this infection is Gordenigo syndrome. Sir, and I can see that there is also enhancement of the muscle.
Okay, thank you. Well done.
Thank you, sir.
Now, this is Petrous epicitis, where there is suppurative infection of pneumotized portion of apex due to extension of mastoiditis. So now the candidate did very well. This was the initial CT scan in which we can see that, the signs which I already showed you. Now here, what is happening on this flare sequence, we can see this high signal at the Petrous apex. On a post-contrast, this row is pre-contrast T1 fat saturated, and this is post-contrast. This is the cavernous sinus. This is the cavernous sinus. Actually, you can see that there is a bit of soft tissue because there is no soft tissue on the other side. And this soft tissue is enhancing. So the infection is extending into the cavernous sinus. And if you see, this is T1 weighted axial post contrast, and you can see that enhancement at the Petrous apex. Look carefully here. This is the internal carotid artery. This is the internal carotid artery on the other side. You can see this enhancement, and the cavernous sinus is sitting there on an axial. So I will expect you to pick it up even on an axial if you don't see, if I don't show you a coronal. By this is irrelevant because the patient also had a PET scan where it was showing up. Anatomy, because the questions will be about anatomy. Now the sixth nerve passes through a canal which is in the sphenoid bone. Please remember, it is not in the temporal bone. This is known as Dorello canal. It passes through it and then goes into the cavernous sinus. But there are other nerves which are passing into the cavernous sinus. So in the cavernous sinus, there is oculomotor nerve, third nerve, trochlear nerve, which is fourth nerve, and then the sixth nerve. The symptoms are because they supply the rectus muscles. Of course, there will be the trigeminal C, sorry, the first branch and the second branch of the trigeminal. They also ophthalmic and maxillary. They also pass through the cavernous sinus. So these questions can be asked in your exam. This picture tells you what happens, that this is that Dorello canal and there can be infection. So the Petrous apex is sitting here, and so both the bones are next to each other, and that is why it will so this will be a question in the exam, that which foramen does it pass, and it doesn't pass through the Petrous temporal bone. So remember that. So this is the clivus, and you can see that this is the Petrous apex where I am pointing out. So this is the apex, and the nerve is passing here through the this is the cavernous portion. So this is passing through the sphenoid bone. Well done, candidate 7.
Thank you, sir.
Okay, this is second last case of the day. This is candidate
9, sir.
9. Okay, that was candidate 8. So this is second last case of the day. This is male 69-year-old, had twice strokes in the past, and they're worried about any new acute finding, particularly hemorrhage. So I will go through it and then I will give you the mouse. I've already approved your mouse, but I'm scrolling it. So this is old infarction, and there was an old infarction here. You go to the base of the skull. I will show you the bone window. Over to you.
Okay. So I'm provided with the CT scan images, bone window. I'll first hold the entire stack.
So just look at the right side, please. Right side.
Okay, sir. Okay, sir. So on the right side, I could appreciate that there is some destruction noted in the Petrous apex with suggestion of some soft tissue density, which I will later confirm on the soft tissue window involving the Petrous apex.
Okay, leave the mouse.
Yes, sir.
This is your soft tissue window.
Okay, sir.
And so
Yes, sir. So there's a soft tissue opacity that is centered over the Petrous apex, and uh, the jugular foramen seems fine to me. I would like to see the carotid canal.
okay, what else would you like to do now? Invest.
Sir, I would like a post-contrast sequence or
You did an MR. You
or an
know,
MRI.
yeah.
Yes, sir.
Please remember, I want to emphasize to everybody, when there is an A and E scenario, then an urgent scenario, as in abscess, etc., ask for a CT. Think what happens in the clinical practice. This is something which is very chronic happening. You can ask for a MR also. So this
Okay,
is
sir.
MR. This
Sir,
MR.
on the MR, yes, sir. I'm provided with the T1 sequences over genes of infarct are redemonstrated. I could appreciate a T1 bright lesion centered in the Petrous apex,
This one,
concerning for,
isn't
sorry,
it?
sir, I think,
So it's a flare sequence. Please.
Okay, okay.
So what is happening?
So there's a flare bright lesion in the Petrous apex. So I would like to see it on the T1.
T1.
Yeah. So it seems bright on T1.
You can
So
move it.
I think,
You can scroll it.
so it's ISO too high on T1. Can I have a DWR?
It was irrelevant. There was nothing.
Sir,
Why
sir,
did you
post.
DWI?
Sir, I'm thinking of some cholesteatoma in the Petrous apex, or so that's why you.
What else would you like to?
Sir, no, I'm thinking as the DWI is very relevant. I would like to see a post contrast.
Okay. Don't move your mouse. Don't move your
Okay,
mouse.
sir.
I will
Okay, sir. Okay,
you when I am ready. So this is post
okay,
control.
sir. Okay, sir. Sir, the lesion was intrinsically bright on T1 and is showing, I think it is showing slight post contrast enhancement as well.
Excuse me. Now
So
you can move your mouse. See the lesion. Move your mouse.
okay, sir. Yeah, so I'm thinking of as it's bright on T1, I'm thinking of a cholesterol granuloma in the Petrous apex.
Good. Thank you. So this was a cholesterol granuloma of the Petrous apex. Well done. So cholesterol granuloma, what happens is that cholesterol granulomas can be in the middle ear and they can be in the Petrous apex. And they take years to develop. You know, there is a study in which they proved that that particular one they had images, it developed in 22 years actually. So the point is that there is a bit of the main pathology to remember is that there is granulation tissue inside, there is a bit of hemorrhage, and there can be cholesterol inside. The key finding, it will be expansion of the bone, number one, either in the middle ear or in the petrous apex. And number one. Number two is that the key find on a T2 weighted sequence, they can have slightly low signal in the periphery depending on the how many blood products are there. But you are going to make this diagnosis on a T1 pre-contrast. On a T1 pre-contrast, it will be high signal. So this is what the candidate was looking for. So that was well done. And so Petrous apex lesion, there is another differential diagnosis. And most common Petrous apex lesion, it is T1 and T2 high signal. So this, remember this. This is another example where there is expansion of the bone, real, much more than our case. And on a T1, this is a T1, this is high signal. On a T2, you can see a rim of low signal here, which can happen because of the granulation tissue. On post contrast, it might not be very helpful because it is inherently high signal on T1. Cholesterol granuloma, this is from the book, that this is how it will look like in middle ear, and this is how it will look like on uh, in Petrous apex. Another one where there is expansion here, and this is high signal on T1 here. So that was very well picked up and well done. And now let me go through the case quickly. So this was the expansion. So if you compare it from this side, so this exactly where I'm pointing out is the Petrous apex, and you can see that there is expansion here. And then we go to the MR. Key thing is not the post contrast, but the pre contrast. Now here, this is a post contrast T1, and you feel as if there is a nodular enhancement here. But if you go to the pre-contrast T1, which I believe was, where was it? This is it. It is inherently high signal, inherently high signal. So the high signal on pre-contrast is on which the diagnosis is confirmed. This is actually, uh, now I'm showing you, this is post-contrast, right? Thin slices. And equivalent T1 is this one actually. And you can see that on pre-contrast, it was high signal. This focus was high signal. So key point to remember is this word and plus the T1 is the key. Well done, candidate 9. Last case of the day. Candidate 10, are you with us?
Yes, sir.
Last case. Now, in this case, what happened is that this is a 53-year-old female, unexplained hearing loss and left-sided tinnitus. Unexplained hearing loss. So that's the symptom, right? Remember that. Now,
Okay.
on imaging, we find is that if you see the white hair cells, they are all opacified, and then there is a opacity here in the middle ear cavity. Now, uh, if you see here, this is the external auditory canal, and you can see that this opacity is filling up the middle ear. This is the malleus, this is the venom, and this is the body of the incus. Uh, there is no definite any bony destruction or anything. Now, with this kind of clinical, what comes to your mind, madam? Over to you. And what will you do next?
Um, there is no bony destruction, and there is soft tissue filling the middle ear and the mastoid. So I'm suspecting that this is my going with infection rather than malignancy.
So there is no bony destruction. So the symptoms were that the patient has got no signs of infection or anything. The only thing is that she has got unexplained hearing loss and tinnitus.
Okay. So I would like to check the nerves, the vestibulocochlear nerves,
What will you,
and sorry,
which investigation do you want?
MRI to check the nerves.
Okay, so I have given you a T2 weighted sequence. Over to you. Scroll it, please.
Okay, this is MRI. Okay, this is MRI T2, and I can see that there is effusion noted in the mastoid air cells. I would like to check the uh, vestibulocochlear nerves. So,
So the nerves were fine on the CIS sequence. There was nothing abnormal there.
okay,
Look at the middle ear.
middle ear. Okay.
Point it out to me, please.
Doctor, sorry, I have problem in the scrolling. There is lagging.
Okay, just leave it. Leave it. I'll scroll for you. So
Okay, thank you.
so this is the mastoid area.
Mastoid. Yes.
Now, this is
The
what.
this is
Now
the
you don't move your
vestibule.
mouth. Don't move. I will ask you.
Okay.
So, what is this structure?
This is the cochlea.
Okay. And what is this structure?
This is the semicircular canal.
Okay. And which part is this opacity filling up?
Uh, this is filling the middle ear cavity.
The middle ear cavity. Now, how do you explain this opacity? What is the signal and what is the signal of the
This is
mass?
hypodense signal in the middle ear cavity. So this is soft tissue. Uh, because the signal in the mastoid, the fusion appear high in T2.
So, what will you like to do next?
Post contrast.
Okay. So, post contrast.
Yes. Yes, the soft tissue lesion that was high low signal in T2 is seen rapidly enhancing now in post contrast. Uh, yes.
So, madam, what is your conclusion?
So I'm suspecting that this is enhancing soft tissue lesions seen within the middle ear cavity. Uh, uh, this may be something related to the schwannoma in the nerves
But
or new.
which nerve will be within the middle ear cavity?
Within the middle ears. So this is the facial nerve.
You know, the facial nerve schwannoma will be in the facial nerve canal. Usually they are not as large. This thing is filling up whole of the cavity.
Mm. So this is but the cochlear nerve will not also be in the middle ear cavity. So yeah, so this is the tympani nerve. Uh,
Madam, the schwannomas do not behave like this, right? Schwannomas are very well defined. By the way, there is a concept of facial nerve schwannoma, which can be in the canal. They are very small and things like that. This thing, this mass is completely filling up the middle ear cavity and it
mm.
is enhancing profusely. So, what comes to your mind?
Maybe meningioma,
Meningioma. Okay.
middle ear meningioma. Yeah.
Okay. So, uh, sorry, what, where am I? This was a meningioma of the middle ear. Middle ear meningiomas are extremely rare but can happen. Usually, meningiomas will occur next to the temporal bone and go into the middle ear. This is a rare tumor which can arise. There are about, I think, 150 reported. I'm sure there must be thousands out there, but 150 have been reported, just confined to the middle ear. Please remember that if you go back to your embryology, surrounding the head and neck, even in the neck, in the upper neck, carotid sheet, etc., you can get meningioma. So that concept should be there. So mostly meningiomas in the middle ear, in the what we call in the temporal bone will be extra osseous. You will see them in the base of skull, sorry, in the posterior fossa, and from there they will go in. But this was unique. But one thing which I want you to please remember, that in differential, in the tumors of the middle ear cavity, And one thing which you would have considered is this thing, glomus tumor. Please remember that there is a tumor which is known as glomus tympanicum, glomus jugulare, which is just at the jugular foramen, glomus jugulotympanicum, which goes from the jugular foramen into the middle ear cavity. When it arises just in the middle ear cavity, we call it glomus tympanicum. And this is also glomus tympanicum, which was sitting on the promontory. So that can be considered in the differential. In this particular case, so what happens is that when you see uh, clinically, when they see these patients with a glomus tympanicum, they they will see a what they call a very vascular or red tympanic membrane, which was not seen in this case. So this is a good case again to learn anatomy. The candidate did well because if you see, it is filling up whole of the middle ear, filling up whole of the middle ear, hypo, meso, and epitympana. And please remember that schwannomas, by the way, that is beyond 2B level, so they are not going to show you facial nerve schwannomas, can happen and they are very small and they can enhance, etc. They will be sitting in the mass, in the, so anatomy is checked there. It cannot be a schwannoma. It is something which is filling up. Now, if you see the T2 weighted sequence, which told you that it is slightly different in characteristics as compared to rest. And again, it beautifully shows you the anatomy on an MR. It is completely filling up the middle ear. And anatomy doesn't change, the modality changes. So cochlea and vestibule, etc., lateral semicircular canal, it is filling it up. And on a T1 pre-contrast, this is pre-contrast T1, and this is how it looks like. But on post-contrast, so there was no restricted diffusion, by the way, in this case. And then on post-contrast, it enhances uh, completely. It enhances completely. And if you look carefully, there is enhance where I'm pointing out, see how enhancement is going right and left. And so look where it is going superiorly. So a bit of meninges are involved. So the point is that this is a middle cranial nerve, middle ear meningioma. And the key thing was that to understand the anatomy of it. Now, if you look carefully, now you will convince yourself. Do you see that this is brain parenchyma? And you
Mm.
can see that the meninges are involved. So you could have asked for a coronal sequence to confirm that diagnosis and how it is going down here also. Sort of a tail sign type of a thing. Okay, madam?
Okay, doctor, thank you.
Okay, then thank you. So today I selected cases in which particularly the last case also, which was to highlight the role of anatomy. And anatomy was the key. And I have actually shown you all cases from one differential of Chapman. And some of these are slightly beyond FRCR, which I highlighted, but this is only one differential in your Chapman, middle ear. So that was the key. And another thing, which is that you should repeat and repeat and repeat again and again. Anatomy is the key. Anatomy is the key. And this is what they are going to ask. Today, I did not have time to sort of grill every candidate on anatomy, but in the exam, this is what they are going to do. So, please remember, what is this? What is this? What is this? So that is the key. Next session, we will continue with base of skull, orbit, and paranasal sinuses. The idea is that in the same go, cover this region. So next session will be similar to today. The anatomy will not be as extensive as of today. This was too much. But having said that, again, you have to revise base of skull. Any questions? So
Thank you, sir.
there was no hyperostosis as far as this case is concerned. Hyperostosis happens when the meningeal cells they go into the bone. This was per se a meningioma which was arising from the middle cranial cavity. And you have to go back to embryology because the meningeal cells are there. They are in the surrounding structures and things like that. So hyperostosis is, of course, more common, and this one was sort of a rare finding. Pars tensa and pars flaccida cholesteatoma. So I'll go back to anatomy to show you the difference. Uh, Pars tensa cholesteatoma and pars flaccida cholesteatoma is the question. So what happens is, uh, consider yourself being the tympanic membrane actually has got part. It is a clinical name. The ENT use it, pars tensa and pars flaccida. And pars flaccida is sitting here for us radiology wise. It is pars flaccida cholesteatoma will be in the Prozac space, which will be in between the lateral to the body of the malleus and the head of the the body of the incus and head of the malleus and next to the scutum. That is why it will cause erosion of the scutum. And on an axial, this is the territory of pars flaccida. So if you see here, this is external auditory canal. And if you go to epitympanum, so this portion is the what we call the Prozac space, where the pars flaccida. On the other hand, pars tensa. Now, I did not go into great details of this anatomy, but I just covered it superficially that this is the posterior. Now, if you see, let me orient you that this is the lateral semicircular canal. This is the epitympanum. I am going into the mesotympanum. I am going to the mesotympanum. Now, here in the mesotympanum, if I stop here, there is this structure here. This is the facial nerve canal where I'm pointing out. This is the facial nerve which is going down. It is going out, right? I come back. Here, there is a strict structure which is pyramid. We call it the pyramidal eminence. This air here is known as sinus tympani, and the air here is known as facial nerve recess. Pars tensa cholesteatoma will sit here actually. It will sit posteriorly. So, and from here, of course, it can go up and down. It all depends on the size. So this is the difference between the two. I hope it is clear now. Is there any other differential of fistulization of lateral semicircular canal? For your exam, they will only show you this cholesteatoma, right? And as far as difference between acquired and congenital is just age. These patients which you will see is always acquired. And Granulation tissue enhancement is never so profuse. Please remember that. Granulation tissue enhancement, the vascularity is very poor. And that is why if we want to do with contrast MR, we do it 45 minutes delay. 45 minutes delay. Why do we do 45 minutes delay? Because the blood supply is so poor. On the other hand, a meningioma, which I showed you, that will enhance very, very profusely. What were the names of the two recesses? So one recess is sinus tympani. Sinus, this one. This is pyramidal eminence, sinus tympani, and this one is facial nerve recess. This is the pyramidal eminence. So these are the structure on the posterior wall of the middle cranial, sorry, of the middle ear. So I think you want to say that how did we conclude that this was a meningioma? Key thing was that it was not glomus tympanicum. Why was it not glomus tympanicum? One thing was the clinical. Please remember, glomus tympanicum, uh, uh, in clinical, it will be what we call a red tympanic membrane. It will be very, sorry, when, tympanic membrane is a very thin structure. When they do oroscopy, they will see a red tympanic membrane, number one. In this particular case, it was scarred. But the key thing as far as radiology is concerned, you remember the signal. It was on pre-contrast. It was not high signal. It was intermediate signal, and then it enhanced like anything. The key thing was the coronal post-contrast, contrast enhanced, where adjacent meninges, the enhancement was extending into the adjacent meninges. So it was a meningioma, and it was not a glomus tympanicum. Can the case of the cholesterol granuloma at the Petrous apex be a nasopharyngeal carcinoma or METS? Not at all, not at all, not at all. So I'll show you, the key signal for what is the key signal for metastasis? Low signal on T1 and high on STIR. So it will not cause expansion, it will cause destruction. So that was not anything else. Okay, then, thank you very much. See you next week.
Recording.